Good morning. Thank you very much for coming, and welcome to our final session on diet, physical activity and the impact on health. And I wonder, could we start perhaps by both of you introducing yourselves to those who are following this from outside the room? So perhaps starting with Professor Dame Sue Bailey. Thank you.
Hi, good morning everybody, and thank you for giving us the opportunity to contribute to this important work. I'm a child forensic psychiatrist by day, and I am chair of the Academy of Medical Royal Colleges, and that's the role in which I'm here today.
Thank you.
And I'm Dr. William Bird. I'm a GP, but I've been interested in promoting physical activity for 20 years in primary care. I'm also CEO of Intelligent Health, which is a company I founded to kind of get more people active and uses technology.
And thank you both for your evidence that you submitted to this inquiry, but because some people won't have had the opportunity to read that in detail, could you set out for those following this debate, perhaps starting with you, Dr. Bird, about your views on the importance of physical activity and health, and your views on really what your key messages would be to this inquiry?
Okay, thank you. My take on physical activity started back in 1995, when the evidence was coming out that moderate physical activity had as good effect as vigorous activity. So walking was as good as actually going to the gym. Now that evidence coming out was not really accepted and taken forward at the time. But for a health professional myself, I was having to try and get the message across to my patients to say that actually they can go for walking, and hence I set up the Health Walk scheme, which was to try and get patients leading other patients, and that's now a national scheme. But the idea was that this was incredibly simple, and it wasn't just that physical activity in its own physiological way was actually benefiting a patient. It was actually liberating a patient out to connect to place or where they live, enhance a community, increase voluntary, increase socialisation, and giving people purpose. And it was those three aspects of people, purpose and place that was the foundation of actually where we get physical activity. It is such a huge area. It is almost that physical activity and life are connected together. So I feel that the medical profession, of which I'm a very proud member to be and have been for 20 years, has got a role, but it's only a small role in liberating the knowledge, understanding to everyone else, giving permission to patients who've got conditions who may be concerned about their entry into physical activity, ensuring that the councils and ensuring that the government actually promote physical activity friendly environments and policies, and also therefore that we actually kind of fly the flag that physical activity is an extremely important aspect. I would say that this is not an option anymore. It's not a nice to have. I've been talking to councils across the country and to the mayors and their chief execs, and I'm saying, if you look at physical activity purely as a medical intervention, then you're only dealing with about 10 or 20% of its benefit. Actually, the rest of it is about that community enhancement, that placement of health. The only other thing I would say is that connection between obesity and physical activity, we've finally kind of got the evidence to disentangle it. I'm very grateful for obesity for getting physical activity on the agenda, because really that's been the way that it's managed to get up onto the kind of podium, really. But actually, what we mustn't do is use weight loss as a measure of success of physical activity. That's how it's always been. It's always been the handmaiden of obesity, the way that you have a diet and physical activity in order for the objective of losing weight. That's no longer evidence-based, and that shouldn't be used again. Of course, obesity is important, but actually physical activity on its own rights has got the benefits. In fact, only 10% of the benefits for cardiovascular disease are weight-related of physical activity. The other 90% are the anti-inflammatory, are the other aspects of cellular change that take place when you're physically active. And finally, I would say that the GPs particularly need to have their knowledge increased. Physical activity should be part of being a good doctor. It's not quite there yet. The evidence is there. It needs to be put in the hearts and minds of doctors. And I feel that the doctor actually does have that role in the clinic.
Fantastic, and we'll be returning to that in more detail shortly, so thank you very much for that. And I wonder, Sue Bailey, would you also like to give your pitch, if you like, on the evidence for this, why it matters, and where we should be focusing?
Yes, I mean, the Academy, which is an umbrella organisation representing all the Royal Medical Colleges and therefore reaches out to 220,000 doctors, this stemmed from our Inequalities Forum when we were looking at things that doctors needed to be able to do and needed to be able to promote. And this is where we focused in on exercise and physical activity. And we felt the important thing to do was actually, as doctors, we work on the basis of evidence base, was to bring together the evidence base. So we brought together over 200 separate pieces of research that shows that regular exercise can reduce the risk, just as Dr. Bird said, of a wide range of other things: breast cancer, bowel cancer, dementia, stroke and heart disease, and prevent it in a significant way. And it can also be part of treatment for serious conditions. And therefore the emphasis of our report has been helping doctors on how to do this. And you may say, well, why haven't we done this before? This may be something that seemed to be obvious. But I think doctors as part of society have forgotten what it takes to stay healthy as we're leading increasingly sedentary lives. And therefore we think that doctors do have a unique place to play in this, because we are trusted and we are in a position, not beyond primary care, to have the critical conversation with patients about the need for physical activity and the benefits it can bring to them, particularly in primary care. Primary care doctor may be seeing more than one member of a family, and therefore the benefits to the family. And therefore we think it's important that we do have the ability and we make the effort and we do speak from the health perspective as doctors, and we have continued contact with our patients so we can follow through and encourage. And what we've tried to do is to break it down into a way that's doable for everybody, irrespective of their background, circumstance or stage of life. And this is why we think this is so important, that it can bring really good health benefits. It fits with Simon Stevens' 5-year forward concept and document, and is very critical to play its part in public health overall.
Thank you very much. I mean, looking at your own report, you talked about the big four, if you like, of preventable ill health, and of those you had the physical activity was down at the list. Why did you feel it was the least important of the four, and how can we shuffle it up the list? Do you think that needs to happen?
The Academy have looked at the big four,
yes.
And I think the others were the more current targets being talked about, and obviously where doctors involved with people who are already ill, they're the ones that more obviously having an impact. And I have to say that I think it was through the Inequalities Forum that I chaired that we said, look, we're missing one
yes.
of the really big issues here, where there are more obvious and easier solutions, and these are things that can make a bigger difference over time.
Mm-hmm. Thank you. So it wasn't that you felt it was unimportant, it was an achievement to get it on the list and to start talking about it.
Absolutely not. This came from the basis of our inequalities work.
Thank you. And to start focusing more on the role of doctors, I know David Shriddon is going to lead off on those questions.
I think that, I'm absolutely very struck by your evidence, Dr. Bird, about the division between obesity and exercise. And I think that's something that people are not aware of. But I wanted to ask you whether you agree with the notion that physical activity is a wonder drug and a miracle cure. And although NICE has recommended that referral to gyms is not a cost-effective intervention for promoting physical activity in the general population, do you agree that doctors and other clinicians should be promoting physical activity as a first-line treatment? I wonder if you both comment on that question, or answer that question.
Okay, thank you. Yes, I do feel that it is a wonder drug. It's a miracle cure. Perhaps not a miracle because it's there already, and it's quite known about the effects it has. And the effects, being clear, are actually right at the cellular level, at the very, very hub of where all chronic disease comes from, which is chronic inflammation. So chronic inflammation is the basis of pretty much all long-term conditions. Physical activity is an anti-inflammatory. Whenever you've done some activity, you actually create an anti-inflammatory environment in the body. So it's not surprising that it does cross-cut everything else in your body. So
do you feel then that the health budget is completely out of balance, and that we are spending a totally disproportionate amount of money on drugs rather than on simple prevention such as getting people to walk?
It's the question of whether that money could actually get people to walk. So if you have, so for example, giving a coronary stent to patients with stable angina or getting them to exercise for 20 minutes a day has exactly the same outcomes after 1 year, except the exercise is more effective. Now the question is whether the money could be used in that walking and promoting, whether it's a health budget or whether it's a bigger budget of council and a wider area.
Could you tell the committee the difference in the costs of those two options, please?
I'll put that in writing, actually, but there is a significant difference in cost and, of course, of hospitalisation afterwards.
But I can help you, can I not, with the answer? I mean, there must be, putting in a stent must have a certain cost. And exercise has no cost.
Exercise has no cost, except we're not getting people to exercise at the moment. And I think you're absolutely right. Of course, going for a walk is entirely kind of cost-free. The question is we haven't got environments at the moment that can encourage people to walk, and we've got to get over a kind of a behaviour function.
Because just following up on that, I mean, if walking is more effective or as effective as going to the gym, then that's completely out of balance. Because we should be encouraging the cheapest option, the one that's most readily available, which is Shank's Pony, walking.
I totally agree.
We don't have to go to a gym. We've got a gym here. Colleagues go to the gym. But actually, the exercise that we get walking to and fro the division lobbies here, which is often walking all day long on a busy day, what you would say is probably more effective.
It is, and I think the first-line treatment, as you're saying, for a lot of conditions like mild hypertension, could be walking to start with. And when I set up health walks, 175,000 of these walks every year through every council. That's money, very, very small amounts of money, because it's all volunteers leading other volunteers, and we have the evidence. So I would totally agree that walking has to be the fundamental part of most interventions of long-term conditions, where appropriate. Sometimes it's not always appropriate.
About 20 years ago in this house, there was a presentation which I attended at the Food and Health Forum by a professor who said that we should really be living the lifestyle of a Stone Age man. That's what our bodies were designed to do. And that involved a lot of walking and very occasional running, and about stalking animals, actually, for food. You agree with that?
I believe that we're still programmed to be hunter-gatherers.
Very good. Professor Dame Sue, what do you think about all that, please?
Two examples, basically. One is in the area in which I work, which is with children with childhood depression. And we know that there's the evidence that exercise there can help. And if that means that we can use exercise, psychological therapies before we use drug treatments, that's what we should do. So there's proven evidence there of its efficacy. And at the other end, I think the most striking thing that encouraged me to want to get this report out was from the author of the report, Scarlett McNally, who works in Eastbourne. She's an orthopaedic surgeon, and just by a level of exercise that elders can do, strengthening bone density to prevent fractures seemed to be not only a great thing to do for elders to prevent everything that comes after that and surgery, but also hits to the heart of costs. So those are the two examples. I think the great thing about this, it crosses the lifespan, and there is the evidence base. And yes, it's regrettable the evidence has been there for some time, and neither public politicians nor practitioners have gone with this sufficiently.
Thank you.
I mean, I think there are possibly reasons. Separately in this inquiry, we've seen people in public health and local government, but austerity and cuts are probably having a real impact. I know that some of the venues where groups meet and possibly do the sort of exercise you've just talked about are in buildings where they've just, in my authority, started instituting charges, which a lot of the groups can't pay, find difficult to pay. So I think austerity and cuts in local government are probably hitting this just at the point where it could, it could potentially move on. And I have to say that, I feel very motivated to do something about this because I'm an MP in the Northwest in a local authority which is probably the most physically inactive part of the country. And I find it depressing and difficult that it's so hard to get anywhere with this, if you like. You note that fewer than a third of adults over the age of 65 do sufficient exercise, and we've also touched in this inquiry on the difference between males and females, and we do understand there's a very substantial gap, a substantial gender gap in activity, and wide geographical variations. I've said I think the north and the northwest are very different from the south and southeast in this. So if you could tell us and the people following this inquiry what you think are the most effective ways of promoting physical activity for these different groups, because we can't talk about this as if it's the same. I mean, clearly, if you live in a deprived estate, and I have some in my constituency, this idea of health walking is not going to be as easy for you to take up as it is if you live somewhere where there's a walk on your doorstep. So that, you know, that there are distinct differences, aren't there, in terms of your environment that you live in, how readily you're going to be able to undertake this. So what in your experience do we have to do to get over these differences?
Well, I kind of use the example of Bob. So Bob's a 42-year-old diabetic, depressed, living on the 14th floor of the tower block with 2 unruly teenage children. So that's the kind of person I will see as a doctor. Now, to go to Bob and give him a badminton racket and tell him he's going to go off and do some sport is really not going to be the key thing. He's depressed, he's stressed, he's got loads of problems. So the kind of area we've kind of gone through before is get off the bus or stop early, use the stairs. These are completely an anathema to Bob. He's got so many problems in his life that to go off on a rainy day to actually do that extra part. So what we have to do, but what he does do, he walks to Anfield, because he's from Liverpool, and he walks to Anfield for 2 miles there and 2 miles back. He doesn't call that exercise at all. That to him is not exercise, that's going to Anfield as a supporter. So what we have to find in everybody, in your constituents and in my patients, is the Anfield part, which will mean that physical activity is secondary to the end. It's a means to an end rather than the end in itself. There are those of us, and probably in this house, who are very, very keen on being physically active and wanting to cycle and do all those things and got all sorts of gadgets on them. But that is a very, very small proportion of the country. Most people see physical activity as work. And we have to look that they will be prepared to do that work if there's a reward at the end. So it is that means to an end rather than the end in itself. And then I think there are 3 things which I mentioned before. It's a socialisation is hugely effective, and in fact some of the evidence now showing that possibly the socialisation of physical activity is more effective in depression than the actual physical activity itself. But both work. The second is place. To get a person to have a welcoming place. If they go to a sports centre or leisure centre or park, it's clean, it's welcoming, they feel unstruck, they don't feel threatened at all. And the final is giving them that purpose. So are they learning something? Is it mean something to them rather than just doing something for the sake of it? So if we can get those 3 things, we've shown that can actually start to motivate the most deprived area of people who are having a trouble in any way in just dealing with their everyday life. And the final thing is, it's got to be absolutely local, to the point of it's got to be in that estate. It can't even be outside that perimeter of that estate. So the health walks, which are being set up everywhere, and Macmillan and Ramblers have now bought the rights to it from the Department of Health, are trying to set it up into every single doctor's surgery. They're trying to get it up to every single estate. And it's cheap. It's incredibly cheap to deal with it. They're all volunteers.
Just one small question about that, though. I mean, surely it's not as if there's no expense. I mean, you are at least going to need, if you're talking about people walking miles, the right sort of footwear.
No, it's 30 minutes max.
Yes, but I mean, if you're a young woman, you've only got stiletto heel shoes, you're not going to recommend she walks 2 miles to anywhere, are you really? So, I mean, there is a question of actually having footwear in which you can walk miles, even if it's not specialised walking boots. There's a switch in lifestyle, isn't there, to being able to start walking regularly, and that if you actually don't have any suitable shoes for it, that's going to get in the way. So I don't think we should say there is no cost involved in walking, because there clearly is.
Okay. Yes.
You need outdoor wear. If it's raining, you need a sort of waterproof, and if you don't have those things, then obviously there's a bit of a cost.
And there'll be a means to an end again. So if they feel it's worth it, they will hopefully do it. But yes.
But I think we need to acknowledge that. I think yes.
I think it's pragmatically doing what you do, but doing it slightly differently. So. My example would be my daughter taking children to school, pushing the buggy. There'll be several of them doing that. On the way back, they'll come back at a bigger pace. They'll go more rapidly. They'll actually meet the criteria of this. And actually, they will have the socialisation, but they'll physically feel better for it. So, that is with almost without cost, I would say. So it's actually looking at the routine in people's life and how they can alter their routine just slightly each week on a regular basis. So I do see the school taking children to school 5 days a week. Here's the opportunity to do this. And I think it's having that conversation with people in the community and or if you're the doctor in the surgery, and thinking of ways that it will be possible, within the surgery, the practice nurses having meetings with young mothers-to-be. There are opportunities there right across the surgery to start having these conversations. And I think the other thing is health professionals themselves are going to have to join in and embrace this.
Mm. Do you think that's the next question really? Are there sufficient incentives? I mean, there are things like QOF indicators to incentivise GPs, but are there sufficient incentives at the moment? It sounds like there aren't, but could we explore that? And I think the other side of that question is, what are the barriers? Because something is preventing, it seems, GPs promoting physical activities, possibly time available. But if you could address that.
Yes, I mean, I've done a lot of training of doctors, GPs around particularly London, going to the practices, talking to the whole practice team about physical activity and then getting the feedback from them directly, which has been a huge experience and great privilege. I would say that QOF came in and came out again for physical activity. It was only there for hypertension for 1 year, and then it was removed again when they did a cull of a lot of the public health aspects. I don't know. I was pushing for it, but I don't think it made much difference in the end. I think
was it too small an incentive?
It was too small, and it uses a GP pack, which is a GP physical activity questionnaire, which is not particularly popular. It's the official Department of Health questionnaire, but it doesn't include walking in its algorithm, which doesn't really make much sense. But anyway, just going back to what the doctors feel, there are three things I feel that doctors feel that will make it worthwhile. One is being a good doctor. So, is the evidence there? Is the clinical evidence right for them to do being a good doctor? And of course it is, but they need their colleagues and they need the higher colleges to actually show the doctors that this is good evidence. The second thing is cost effectiveness, and the CCG will tell the GPs that this is cost effective. And the third is actually the patients, the stories coming back from a patient. We get a lot of feedback from our patients, and if you do something and it makes a huge difference to their life, that really does reinforce it. So what was happening is that the evidence wasn't being pushed out there, the cost effectiveness wasn't very clear, and they still hadn't quite got that connection with the patient. And the biggest problem with the patient, going back to the example of a stent or physical activity, is the patients often weren't ready to be told they've got to go for a walk in the park when there's a nice shiny stent and a lovely brand new hospital down the road, which they felt was much more worthy to have that. That's where science and technology was at its ultimate, and they were just being told to go for a walk. So the patient's expectations weren't met, and the doctor felt uncomfortable very often in promoting that because it wasn't really what we've been taught to do, and we haven't got the confidence to do it. And then finally, the patients have fear of physical activity. Most of them have never been out of breath because they've never exerted themselves to the point where they're actually going at 70% of their VO2 max, which is a 3-mile-an-hour walk. So they're walking incredibly slowly. So to get to the point of being out of breath is really quite scary, and that's another aspect when they come back to the doctor and say, I can't do this, it's too dangerous.
We've touched on, I think, or certainly there's the Sport England campaign, This Girl Can, which is just showing images of women taking vigorous exercise, sweating. Do you think that's a good idea? I mean, given what you're saying, if people don't think, because clearly that the message in that campaign is it's all right to get sweaty, out of breath, go red, look terrible if you like for women and girls, and particularly to get over those barriers. But do most people need that message, that information?
I think I've from the experience I was getting from GPs, yes, there needs to be. I mean, that campaign is excellent. It's really raised in profile, and I think it's been very effective in its pitching of where it's reached to women. But we forget that barrier.
I think that's the very reason why in our report we've focused on the how-to for doctors, because of the very reason the feedback that Dr. Bird's got from practices, that what we've focused on is a very simple set of model of how doctors, their role in changing behaviour and changing culture, and the how to do it themselves, and how they can explain that to patients, and really the do's and don'ts of how to apply that. and why we've put a quick guide to recommending physical activity, because we know doctors across the whole field of primary and secondary care are very busy, but this has really got to be embedded into our routine thinking and practice, and to do that we've got to feel confident in doing it, and we are the people who are there able to give appropriate advice about what a particular individual can do in terms of physical exercise. Therefore, I think there's a hearts and minds and a training issue here that the Academy are very keen to address.
Could I just talk about savings? There's a comment here about savings from the evidence based on the benefits of regular exercise. The report highlights estimates that up to 15% of the NHS budget could be saved in the cost of treatment and care if the population took appropriate physical activity. That's a staggering amount. I mean, it would obviously be very helpful to put a total figure on that, I think. But, you know, given Simon Stevens', you know, push and the whole thoughts of what the gap is, the funding gap in the NHS, is it not surprising that there just isn't a bigger push to be able to get to those savings? That there seems to be a reluctance to embrace what you're talking about. And yet the savings that could emerge from it just seems so substantial. This just seems like the most peculiar gap to me. That here is something that's beneficial, and it could be, you know, financially of great importance to the NHS in terms of savings.
Sadly, it's not unusual to encounter belief gaps where you have solutions that are simple. So I work in the field of mental health, and a belief gap that actually parity for physical and mental health will actually save money. It has to be fought, and it has to be argued, and it has to be evidenced. And I think this is something we just need to keep attritionally doing and demonstrate the benefits, not only the cost savings in this area, but across the whole area of public health and public delivery of services. I just apologise for nipping in and out. I'm afraid I've had a couple of urgent calls, so my apologies for being so rude. There was just something, Dr. Bird, that you just mentioned in passing. You said that walking wasn't part of the algorithm of the survey, which I detected that you found unfortunate. What does that say about, I'm astounded, because what does that say about the culture of DH and the systems we work in, that walking shouldn't be part of the algorithm, that anyone with any kind of common sense would have thought it was? And is that the point we need to target to try and get change to diffuse throughout the system?
I mean, it is a good point. The problem of physical activity is that it is hard to measure compared to BMI or compared to smoking or compared to other things where we've got nice figures and we've got near-patient testing. So we are struggling with it. Now, GPPAC, which is a physical activity questionnaire, was taken from a massive study called the EPIC study, which was done from cancer around Norfolk, and it's a European study. And what they looked at is what really made a difference on mortality from physical activity outputs. And it was actually work-related outputs, cycling, and I think one other. But actually walking, housework, gardening, everything else didn't fit in. But they asked the questions, and you still ask the questions, but actually when you look at the back end of it, it doesn't connect. So what GPs have told me was that they find that very difficult when a patient is actually walking 5 days a week for an hour, as Professor Bailey's report said, you know, that is where we should be going for. And then it comes out they're inactive because of. So it is being looked at. A lot of CCGs are thinking about using a different measure, and we are still, I think, in that kind of turmoil of trying to find out what's the single measure we should be using. There are 2 or 3 out there, but includes walking, because it isn't really right at the moment. And
forgive me if you've already covered this when I've been out, but you've got apps and things which you can use as pedometers and things like that. Is that changing the way that people can measure things? Because it's a very good one of, watching progress and measuring progress for someone particularly who has perhaps some mental health issues, and watching that building and that achievement is also very, very good for mental health as well as physical health. Are those kind of apps and pedometer things helping, or are they?
They are. There's no evidence to show that apps actually change behaviour for physical activity. They're very good at encouraging more behaviour on people who are already active. So it tend to be, even though everyone's got a smartphone right across the board, yes, they can be used and incentivised. And there was a study of pedometers and Glasgow Rangers where the middle-aged men were incentivised to actually, if they got a certain number of points, they went to actually on the hallowed turf of Glasgow. And that was actually hugely beneficial for the pedometers on that. In general, though, I don't think that's part of the issue, and I don't think that's enough evidence to show that actually pedometers widely can be used at the moment, but that may change.
Yes, so building on good points that Charlotte's made. I must say I find it quite distressing to think that we now have a culture where patients prefer going to a shiny new hospital for a stent rather than taking basic walking exercise. And isn't one of the core problems that we've got with the health service that people no longer care for themselves, that they believe they have an absolute right to pitch up at a doctor's surgery or an A&E and receive some treatment of some kind which exonerates them from taking any action themselves?
I feel that the role of a doctor is very often there's a fear of patients. So although the internet's got loads of information there, patients come often with that information, but they don't want to take that full responsibility of it. They hand it to a doctor. The doctor, hopefully for a good doctor, repackages that and hands it back to the patient in a format they understand and they can cope with. And therefore, I don't think it's wrong that patients coming to us with fear and wanting to hand that responsibility on, because fear is a big factor in much of this. Our job is to have that compassion and to be able to hand it back to them, but having explained it, and then the patient actually continues that responsibility and moves forward.
But to be fearful of taking basically the basic exercise is something that it clearly has to be addressed. But if you look at things at a macro level, much of the work of this committee and this Parliament has been dealing with the so-called Nicholson Challenge, coined by our former chair, Stephen Dorrell, the inexorable increase in demand for services and scarce resources, and trying to find ways of bringing that together. And surely one of the ways that what we're discussing today, basic exercise, could be a significant contributor to the Nicholson Challenge in reducing costs. We can't go on. Surely the focus is far too much on increasing supply and far too little on cutting demand for services.
I think as doctors we're in the business of values-based care, and the second limb of that is value and cost. But I think this goes to the heart of what as doctors we need to do in conversations with patients, that we add the advice beyond the evidence, and it's where we have to be able to help them choose wisely about their treatment path and what they're going to do in terms of self-care, self-help, and what we can offer them.
Isn't, unfortunately, there a built-in incentive for the medical profession to promote expensive treatments, because it's through those treatments and through the tariff system that people get paid. So there's actually a disincentive to have the simple option of taking exercise.
I think as doctors are increasingly involved and must be involved in health prevention, then I think our duty is to help patients choose wisely.
I feel that it is often more difficult to promote something simple, and walking is almost too simple. The reason I set up Intelligent Health was to add technology to walking so that everyone can do it, and then suddenly everybody actually finds walking is attractive and they put money into it. But when you have walking on its own, it's almost too simple, and the kind of mentality of health is that you need treatments and you need packages to actually help. So I feel that there is a kind of psychology kind of the way that we deal with health, which we have to work. And I do feel that as doctors we have that responsibility to change those expectations of patients. Every consultation we should be not giving the antibiotics. We've managed to win that. That's starting to really take effect, and we can do the same, I think, for physical activity.
Chief Medical Officer Dame Sally Davis has been in front of, I think, the Science Committee, which I also sit on, but I think she's been in front of this committee as well. So many meetings this Parliament, and she wrote a book called Drugs Don't Work. But unfortunately, the evidence that she's provided, there's very little alternatives presented other than the need for more money to try and find antibiotics which people should be using less, which is not a very attractive proposition to companies. So isn't it absolutely critical that we roll this out on a wider scale to try and meet these problems that I've already described? I'm asking you something, you've got to say yes to it. Hardly say no. Then I want to ask you, maybe we should keep moving on. Think about that, please. How helpful was the NHS health check in promoting physical activity? Can you tell us about that?
Yes, I mean the health checks have been a way of getting people aware of what their risk factors are, and it's been very good at getting people aware, and it has actually, in the evidence that I've seen, actually reduced blood pressure. It has reduced some of the areas, not smoking so much. I haven't seen any evidence that it reduces mortality from it, but as a way of getting physical activity into a conversation for a patient, a health check is a very good way, as long as the provider of that health check has a connection to understand about what they should be talking about in physical activity. And unfortunately, and I quote someone who is a very avid, in fact a GP, who went to his own health check in the practice, and the nurse said, I'm meant to be talking about something about physical activity, but I'm not quite sure what it is. And almost that summarises the effect that there was a tick box to talk about physical activity, but it didn't mean much to that nurse because she'd never been told what physical activity was about. And there's a massive gap there that I think we need, and I think the report comes through very strongly, that actually doctors do need, and nurses do need to be upskilled in the knowledge of physical activity, and then that would make the health check much more effective on the physical activity promotion.
Right. So, Professor Dempsey, just going on from that, you have touched on this, but how well do you think the average NHS clinician understands the importance of physical activity?
I think we've a way to go and a way to travel, but we've got a determination. We've got a way of reaching 220,000 doctors, and we need to ensure that this is bedded in terms of doctors into medical education from the first day of medical school.
Isn't there a problem with doctors' education? There's far too little emphasis on prevention, and it's the training tends to focus on treating specific conditions.
I think in the education, in the curriculum, there needs to be far more about prevention, understanding single conditions, and in fact most people have got multiple conditions, in terms of the functioning of the patient and the social context. And the curriculum is changing and will continue to change, and I think there's an opportunity going to be provided for that in the future shape of training.
Do you know offhand how much, what time in the teaching schedule of doctors is allocated to issues to do with physical education?
No, I can certainly find out. I suspect what it will be is that the training will be spread across a range of topics within the curriculum, and maybe what needs to be done is it needs to be recognised as an entity rather than just appearing in separate parts of different parts of medical curriculum. But I can certainly come back to you with that.
Thank you. And a couple of final questions. What more do you think needs to be done to win the hearts and minds of physicians about promoting physical activity? And do you think medical training in this area needs to be expanded?
I mean, I think for hearts and minds, when I started teaching GPs about physical activity, I got it all wrong. I talked in a public health language. I'm a GP, but it was about prevention. It was all about statistics and tables and things. It was only when I started talking about the actual physiology, when I talked about the cellular level, that it started to reconcile with their mind of a medical model.
It's an interface issue then.
It was, and then they fascinated that physical activity had effects on the cellular part, which was causing all these diseases. They then bought that, and then they owned it, and then suddenly physical activity was owned by those doctors. You could see it very clearly happen. So I think the way it's presented is actually quite important. And then those same doctors were then talking about the school crossing almost 20 minutes later, because now physical activity was their responsibility. So I think doctors will accept physical activity. Don't think it's not just a prevention, it's treatment as well. So we have to explain that almost every condition can be treated. And I think there is a gap that we've probably not been very good at filling in getting that knowledge to GPs and all doctors, which I think is there, and I think they will accept it when it's being put in the right way.
Thank you.
Could I just follow up with a couple of points that you've raised about some of the areas around issues like QOF? They're very process-driven and tick-box-driven. And I know, Professor Bailey, you've touched in your evidence about how you have this unique opportunity in a healthcare setting to catch somebody just at the point when they're ready to change behaviour. And if at that point what they encounter is somebody who, as you put it, Dr. Bird says, I'm meant to be talking about physical activity. You know, that's not an inspirational moment. So we've rather focused on incentives and tick boxes. How do we change this within doctor surgeries to make sure that every contact really does count as we want it to? What do you think would make the biggest difference?
I think an overall approach, and I think we have a way forward with this document. And I think what we need is probably Dr. Bird's duplicated. We need actually doing all sorts of learning. You can always have the e-learning package. What you then need are some product champions who will go out, explain the benefit, not only the benefit to the patient, but how it will make the whole functioning of the surgery better. It'll make it a better, more positive place for not only the patients but the staff working in there.
Yes.
And I think it is our hearts and minds, and I think it's not tick boxes, it's action with intent, with evidence, and with an attitude that this does work, it will work, and we cannot afford not to do it.
Yes, so in fact having inspirational people going into surgeries, teaching a whole practice team that this really does matter and that they're failing their patients if they're not capitalising on all these opportunities that they have to really be leaders in driving change in people's lives.
I would turn it that they can greatly benefit their patients.
Yes.
And because I think you have to frame things in a positive if you want people to change behaviour.
Right, so you would say get inspirational people into surgeries to change behaviour. That's the most effective way. And it was a disappointment, I think, to many people that the NICE guidance came out saying that it wasn't cost effective to have exercise on prescription because of course doctors are used to handing prescriptions to people, so it kind of felt like an alternative to using drugs or referrals, so I think there was a lot of hope that would be more successful or cost effective. But do you feel part of the failure was just that it literally felt like a prescription, something handed over, a kind of I'm meant to be talking to you about exercise? Was that why it wasn't so successful? Do you feel that there were ways that we could still use this as an opportunity, as an alternative?
I think the context in which advice is given is really important. That includes to doctors themselves and how they understand the advice that we're given.
Right.
And I think there's far more work needs to be done about that. I think that will fit with whole patient care, and I think that will be core to future shape of training. But we need to do the catch-up with the current healthcare staff that we have.
So do you think that the future shape of training review is going to be a pivotal opportunity to change the way doctors are going to be putting these messages across?
I think it's about future shape of training at its core is about how we have conversations with our patients, how we understand whole patient care, and how across the whole medical profession we look at the whole patient, their whole needs, and how this physical activity can be a pivotal part of that, which is going to give better care and better outcomes. So I think it is a change of attitude and giving doctors the confidence in giving those messages and how to do it.
Thank you. Right, we come on now to number 8.
Thank you. To what extent, and it's going to be a difficult question to answer, I know, do you think obesity is a symptom or a cause of mental health issues?
That's going to land with me, isn't it?
I want both of your... I need both your opinions.
Okay.
Right, okay. Well, we've two major challenges here. So one is, whichever way we wrap this up, we know that the treatment we give to people with mental health problems leads to weight gain. We know that. But there's really good news from Australia and trials going on over here that we can now minimise that weight gain to no more than a woman going on the contraceptive pill. That's a major step forward. Then you've got the mental health problems itself. You become preoccupied with your thoughts, you get withdrawn, you stay in, you need to find comfort somewhere, and eating is part of that. So it's both. It's like everything, it's both. And it's the approach you take with somebody from mental health problems from day one when you identify that. And it's the attitude you take with them and how you try and help their sense of confidence and self-worth, and how you help also support their carers, because it's not just mental health problems, you look at the same sort of things around dementia as well. So it's both. There's not a nice, clean answer to the question.
I feel nervous talking in front of Professor Bailey on psychiatry, but I feel that this is a symptom of a bigger epidemic of chronic stress, where there's people really don't feel they've got that kind of that well-being side of things. And of course, with chronic stress as opposed to acute stress, which is quite healthy, you get the kind of constant corticosteroids coming through, the glucocorticoids coming through, which are causing havoc in our bodies. And therefore obesity is far more likely to occur in those people because you've got cortisol going through, and which creates weight gain. And it's a way that body survives. And the fact that if you feel that you're going to be stressed and about a famine, war, earthquake, whatever, you actually want to conserve as much energy as possible. So you become more inactive and you actually conserve more fat. So we've got this whole chronic stress issue, which is underlying a lot, not just in the deprived areas, but in other areas as well. So obesity follows on from that. And then, of course, it's extremely difficult to then undo that while you've still got chronic stress there. So while people are still living in a really bad environment, are isolated, have got no purpose in life, you have therefore got an almost impossible way of trying to change that obesity. And this is where I think there's been a mismatch from people saying, oh, it's so easy, you just have to go on a diet, you just have to do this. But if you're in that state of mind, there's no way that's going to be effective, and it's going to be difficult. So if we're going to talk about the real problem, it's not just obesity and physical inactivity, it is actually the inequalities and chronic stress, which is...
Rather like the thought of telling a depressed person just to cheer up.
Exactly.
Yeah. One thing, and if you feel inadequate talking about it in front of Professor Bailey, I certainly do. And something I'm going to come to another question in a sec, but something I've not heard talked about, and I just wonder what your reaction to it is the sense of lack of control. Because I'm in my constituency, which is very varied, I look at the communities that suffer from obesity, and they are communities which don't feel they have very much control, where individuals don't feel they have very much control over their own lives, and the community doesn't feel it has very much control over its destiny, and its collective self-esteem is very low. And I wonder whether eating and is in some way, even though it's or eating and perhaps often goes hand in hand with alcohol or substance abuse as well, is some way of taking control, even if it's in a negative way, some way of taking control in a world where you don't really have control over anything else, and whether sense of self-esteem and autonomy is a valuable things in terms of tackling the obesity epidemic. Does that make any sense?
Mm-hmm. I mean, I can just probably say yes, lack of control obviously contributes to that whole aspect of chronic stress, like in the Whitehall studies done where you had that lack of control as one of the big risk factors for mortality. And of course, eating, comfort eating, etc., is very, very connected to the evidence to show that if you are chronically stressed, you will want to take in more calories and sort of fat and sugar. So there's no doubt eating behaviour changes when you haven't got that control because you've got that chronic stress. So there is a very, very strong relationship. And then, of course, physiologically in the body, then you've got the double whammy where actually that fat is laid down more. And in the area of inflammation, which we talked about as a kind of basis of all chronic disease, if you are stressed, you will create much more inflammation, chronic inflammation in the body. So you've got a pathway, really, of a poor environment, isolation, no work, no job prospects and no control, chronic stress, chronic inflammation, disease, and inactivity and eating are the kind of two drivers that keep it going.
It's very refreshing to hear you talk so much about causes and not just about symptoms. In our collective response to obesity, do you think we are concentrating enough on causes of obesity and as opposed to the symptom, which is obesity?
I think I would rather look at the solutions, and you talk about communities that face adversity and exist in difficult conditions, and they can't see the point and they can't see any exit point. And I think this is fundamentally about how we build psychosocial resilience in communities that suffer chronic stress and adversity, and communities that are busy minding their own business one day and then suddenly an adversity hits them from left field. And I think this goes to the heart of psychosocial resilience building and how you build social scaffolding in communities. And I think there is growing evidence that's coming from two fields, one of that of individual trauma, so people have been abused, and also from group trauma, and the scientific evidence that's coming from this, which is underpinned by the neurobiological evidence, suggests how we can build psychosocial resilience in communities. There's new work occurring on that. Our college is about to write a book on it, and you will all be the first ones to get a copy of it when it comes out. But I think you go to a heart of very important and very large matter.
Do you think that the way you're tackling it, which is very much let's look at the root causes and let's see if we can help mitigate those, is prevalent enough in the way we look at our health services? Because we haven't had, perhaps I've not been at the right meetings, but we haven't had very many witnesses who have gone to the heart of the problem in the way that you seem to be doing. And it seems to me a shame that you should be unusual in that virtue.
I think life's what I call life is at sort of second base. We know what the problem is, we know what the causes are, and it's always the biggest hurdle to go to third base and to start to action. And I think that's what needs to start to drive across medicine now. Action we can take that's simple, that can be done by doctors, can be done by health, can be done by communities, to reach fourth base, which is a healthier community in 2040 with good public health. So we just have to keep at it.
I think it's becoming more kind of, I'd like to think mainstream, perhaps not quite mainstream yet, but I mean, for example, and it's one of the things we haven't touched is the environment, which I know has been dealt with before, but actually it's one of my other areas of interest, and another book that's coming out, the Oxford Textbook of Nature and Public Health, you can all have it in July. But actually the way...
Do you have a series of questions
specifically
on the environment?
Okay, we'll leave that. But that's the way you can green and create an environment where that chronic stress is reduced, and the evidence is really quite strong now coming through on that in Chicago. I think it's the well-being. I'm still a GP and I've never moved into public health, even though a lot of what I've been doing on activity in the Met Office and other things have all been public health, because the root cause and understanding of people has to be by seeing them day in, day out. So they're my policy advisors. They're the people who I feel guide me when I feel like... Yes, exactly. And if you kind of become dissociated from your constituents, from your patients, you've lost the plot completely. So I feel that doing public health, but on a grounding of general practice, is actually a really strong place to be. And one of the things I've always tried to promote is that actually public health and primary care should really come together in the same individuals, so that this continuity, so we can talk about this higher level, second base and even third base.
I'm going to have to add even more reading. The Academy produced through the work of the Sustainability Valley at the Royal College of Psychiatrists, its report on waste and sustainability, and the two main planks of sustainability are disease prevention and self-empowerment. And I think it's that approach that will win through with time and effort.
So do you think perhaps one recommendation the committee could consider in doing its report is a greater focus on things like building socio-psychological resilience and self-esteem in order to tackle the root causes of a lot of the things that we spend a lot of money working on the symptoms of? Sorry, I've gone on. I'm sorry, it's very interesting. Sorry,
can I just touch on a slightly related area? And there's something that concerns me is a suggestion that we might be looking, or the government might be looking at enforced referrals for people with conditions like obesity as a condition of benefits. I know they've asked Dame Carol Black to look at this. I mean, I have great concerns about any concept of coerced consent or referral. But in terms of your thoughts about whether it would even be effective, I mean, could you perhaps share your views on those proposals? I mean, do you share my concern about the idea of coerced consent and about whether it would be effective? Would you like to maybe comment on that, Dean?
I think this is a difficult area, and I don't think we're even at first base, because we know from studies that you have patients who do have obesity where as GPs have sat in certain surgeries and never even raised the issue with them for 20 years.
Yes.
So I think before we go to that point, I think we have things to do in our own house, and then we need to look at ways of engaging.
Yes.
And I think we're a long way away from that.
So I guess one of the reasons maybe for looking at it would be the theory that it's a way of at least engaging and forcing people to engage in it. But there are other issues around it, aren't there? Clearly, I mean, I'm
hesitant as a forensic psychiatrist when I hear the word coercion.
Yes, indeed. I don't know whether this is something you've been following, Dr. Bird.
No, I haven't actually been following that. I mean, I think just going back to the exercise referral, where the evidence was shown inadequate and it kind of petered out. I mean, what that did show, though, that was very, very, very prescriptive in gyms, because the evidence always takes so long to come through. So that was really a lot of work done in the 1980s and 90s. Newer work now is showing that actually once you've got that patient engaged, that Enfield moment almost of the patient, and they've got engaged and they accept it and they're part of them, and they will then change their behaviour.
Yes.
The medical profession's got a really small role, an important role, in perhaps initiating that change, But after that, it has to be the patient enjoying it and feeling they've got value. And I think we sometimes overestimate what we possibly can do, because exercise referral was to try and throw someone into a gym who probably hated the gym and expect them somehow to go on forever in doing something they don't like doing. And most normal people don't do that. So I think from this, any kind of coercion of referral, we have to accept what effect would it have, and the effect is it has if it gets someone to a place where they actually like it and they wouldn't have done it otherwise, then that's a good thing. But we can't make people do things that they don't want to do afterwards. It has to be a positive experience.
Positive experience. Thank you very much. And I don't know whether you wanted to add to that, Barbara, with the...
The question really, just if we could come back quickly to it, about local authority planning decisions and the idea of having a mandatory health impact assessment. The question for the committee is really what impact the environment has on people's ability and motivation to be physically active. Dr. Bird, you might come back to touch on, I think you're talking about some evidence that emerged in Chicago about the impact of open space on people's well-being, didn't you? Was that what you were referring to? Because
yeah.
I have to tell you, I've quoted that when I've been trying to appeal against building on green open space in my constituency, and you get nowhere with it, unfortunately, at the moment, because it's not part of the national planning framework. But perhaps if you could tell us, the committee, what you think on this issue.
I think the environment now has often been forgotten, and particularly from medical, even public health, it's such a difficult area to get into because so much of it is sort of obviously there and it's expensive to change. But we've seen in places, even in New York, where they managed to start to change the environment temporarily initially in order to get over the boundary, and then it got more people actually talking and walking and mixing, and suddenly the whole social cohesion came through, and the health benefits have started to come through now with the measurement. So even in an area where you've got real barriers, there's been effectiveness. And Chicago was 1 million trees being planted by the mayor, who saw the University of Illinois came up with some, Professor Kuo came up with some very, very good evidence to show that green space actually encourages social cohesion and actually gets people to become more active, less stressed, and therefore domestic violence went down. Huge things that you wouldn't even expect to be associated came through from very simple measures. And physiologically now we've got all the PET scans to show the brain changes when people look at green space. It actually does for Alzheimer's patients, it changes. So there's a whole massive evidence out there, and the book I'm showing, going from Harvard to Stanford and everyone, are all looking at this much more seriously. It's Professor David Tretling would be very pleased to know that this is now no longer just on a fringe. This is now mainstream medicine, and it goes right into the heart of planning, that we have to have environments which are now conducive with all the evidence we've got. And I feel that health impact assessment, I almost feel like I don't like making that mandatory side. It should be common sense, and the planners should be so informed and empowered with this that they should be doing it themselves.
I agree, but I mean, realistically, if it's not in the national planning framework, if it's not mandatory, they're faced with legal challenges, and I think that, in my experience, most local authorities are more worried about the six-figure legal bill that they're going to get if they're challenged. A builder, wants to build on green open space, has that power, I think. So I would argue that's probably why it has to be mandatory. But
I think the Faculty of Public Health within the family of the colleges of the Academy have a lot of evidence about this, and particularly work in Liverpool and Glasgow. I think it goes back to the heart of community engagement and finding a starting point.
It certainly is my experience that we've got targets for house building and road building, but not targets for keeping anything, and certainly not for putting in more trees. We seem to be going in the opposite direction all the time. It's very depressing.
We should be just using green space as a health resource, and it has a health value, and therefore when it's taken away, that health value is removed. That seems to be the kind of mentality I think we should be looking at it.
Is there any work going on with the planning establishment to do that you know of? Because this seems to be a big thing that's being ignored to me.
There certainly is. I think if you look at the Liverpool Public Health Observatory, there's work there going on with the chair of the current faculty of the Public Health Faculty, and across the universities there. There's currently work going on in Glasgow about making slight changes to green spaces that have been seen as not safe green spaces, but just by community bringing about slight changes. And there is then tended to be an acceptance and less an acceptance by local government that some spaces can stay. But I would advise you to go to the chair of the public health faculty. I'm very happy to give you the contact.
And in Birmingham, they're trying to get the status of a biophilic city. So biophilia, the connection with nature. There's a kind of international way of actually making your city a biophilic city, which is basically green space is prioritised. And Birmingham are going through that process at the moment, so there'll be another group to talk to.
There was a very good example at the Warnford Hospital where the local community and the mental health hospital came together, and they've preserved the green space between the community and the hospital, and the mental health and the community come together to retain that green space, and just the advantages that have been described. So that was in Oxford as a very practical example.
Thank you. Thank you. Could we just go on to the issue of the responsibility deal, so changing the subject somewhat and looking at the influences on diet that we can have through that. Do you feel that these voluntary agreements have been successful? I mean, do you feel that that we need to go down a regulatory route? Would either of you have a view on that?
Answer the first half of the question, have they been successful? No.
Mm-hmm.
We still have hospitals that have certain shops at the front of the hospital. We still have the sugary drinks. We have all these things still pushing against our efforts to move things forward.
Mm-hmm.
So I don't think it's been successful.
What would you feel about having a tougher regulatory regime, and what do you think would be the most effective of those measures?
If I had to go for one, I have to say it would be the sugary drinks and the tax on sugary drinks.
Right. And how about yourself, Dr. Barrett?
I won't talk about the diet so much because physical activity is
yes.
the physical activity part of the responsibility deal I've been working with. In many respects, that's slightly easier and less contentious because hasn't got the kind of the alcohol or dietary kind of impacts of industry. And I do feel what difference it's made in the future, I don't know. But from being there and looking at the companies who've been involved who are making pledges about their own workforce, but also on putting money into physical activity, and it is all the big names like Coca-Cola and others who are all pushing forward, I feel that discussion is good, and I feel that we should be talking to industry who use their ability to connect to people in a way that we can actually harness that to connect to people in the ways we don't often do very well. I think as long as there's an absolute open discussion, it's very frank about what people are wanting out of that deal, and there's an honesty at the table, then I think those are the discussions we should be having. As I say, I don't know what the effectiveness that's had so far on physical activity. I'd expect very little, if none, but it's a way that perhaps that discussion has gone into some of the big industries in this country, which is probably not a bad thing, and I think could be quite positive for the future.
Do you feel, Dr. Bell, that there's a danger when you see the promotion of sports drinks, for example, to children, which may have very high levels of sugar? I mean, do you see any circumstance under which a child would need to have a sports drink? Then these are often sponsorship-type arrangements. Do you see that as a danger?
I mean, I think in a kind of very, very kind of modest context, yes, sometimes children will need a little bit of additional kind of energy, but certainly not to the realm and the way that it's been promoted, that actually you have to have this sports drink at the end of any activity that you do, and the activity can be 15 minutes, which is no way going to actually compensate. So I feel that there's been a way, it's been scientised, it's been kind of created into this great industry that you have to have all the gadgets and gear and things to become active, and you have to have all the nutrition and the drinking, etc., to become active, whereas actually you don't need all of that. It's very simple. Yes. But I wouldn't want to say that you can't have a treat or anything afterwards, because otherwise we're starting to become into the kind of more telling people that they can't do anything. But it's the way it's promoted, I feel, is probably overdone, and it's perhaps even a barrier to people wanting to do activity because they feel they've got to have all this apparatus around them.
Thank you. And if we look at the obesogenic environment and the sort of the low physical exercise environment that we have in our society at the moment, if you were, both of you, going to say take a what works approach, what would be your key messages that you would want to come out from this inquiry? If you were saying what should we really prioritise, what would you say they were, Dr. Bell?
Environment. First of all, I would say that from the environment for physical activity, we did some work in Natural England, and there was 5 generations of one family. The oldest great-grandfather had a 6-mile radius of being able to have free play at 8 years old. The child now has less than 300 metres of free play, and actually now, that was 4 years ago, now a lot of children have 0 actual, because they can only be taken to places, so they have no more free play at all. That's having a major effect on children's ability to learn, but also to actually become active. Most of the activities when they're outdoors doing free play, not sport, it's just free play. So we have to have an environment that says that is just not acceptable, and the walking. And the other thing I would say is that we need to understand the community of what actually people value to want to become active. So the whole voluntary sector works on people being active. A whole community connecting together works on people being active. If you have an inactive society, you have a dead society, you have a dead city. And we have to look at where that environment and social meet together in housing estates, etc., to improve that way of making it valued to become active, to volunteer, to keep that cohesion of the community. And physical activity will follow as a secondary rather than being as a primary.
Thank you. And yourself, Professor Mayor?
I could not disagree with that, and I think it's in the embedding of this and actually getting what communities actually want, what they'd like to achieve, building the psychosocial resilience. And I think the pragmatics that follow on to that is giving people awareness, education, giving them the facts, helping them to self-empower and following through with action. And from the point of view of our report, getting doctors to better understand this and to realise what the impact of their actions could be if we're going to have a healthy nation in the future.
Thank you very much. Do either of you have anything you would like to add to that? No. Thank you. Thank you for coming today. Hello, thank you very much for coming.
Okay.
And I wonder, could I start by asking you to introduce yourself to those who are following from outside the room?
Sure. So my name's Julie Creffield, and I would describe myself as a plus-size athlete and entrepreneur. And I run a website called The Fat Girl's Guide to Running.
Yes, thank you very much for coming today. And I'm going to hand over to, first of all, to my colleague Barbara. Thank you.
Well, perhaps you could tell us more about your campaign, because it's not just that you're involved in getting more people active, you're specifically, as you've said to us, encouraging plus-size women to be active. So could you tell us how you started that and what you do?
Yeah, so I got into running when I was in my kind of early 20s, and I'd put on loads of weight while being at university and wasn't doing any regular exercise, and I got involved in a fun run. And it wasn't any fun because I was so unfit and so overweight, and some child shouted, "Run, fatty, run," and I just sat in my car and cried. And so I was really determined to change my health. I wasn't necessarily worried about being fat, it was more about the health implications of being overweight. So I started to run, but I did it in secret at night, didn't have any friends that run, so I was completely by myself. And probably did that for 3 or 4 years, signing up for races, not training properly, having terrible experiences at these races, and never really saw any progress. And when I looked online for information, there was lots about weight loss and running, but nothing about running just as an overweight person, and the psychological aspects of that and how tough it is when you are just constantly shouted at, laughed at, clothes in fitness stores don't fit you, so it just feels like the whole sport is not really geared up for you. And then I think the catalyst for me starting my blog was that I came last in a race, and not only did I come last, but packed away the finish line. And I just felt incredibly embarrassed and thought, actually, this must happen to other people. It can't just happen to me. And I started writing a blog. And by that point, I had committed to running the London Marathon, even though I couldn't run really for more than kind of 20 minutes at a time, but that was my goal. And the blog was really to keep me accountable, and over time I realised that people were interested in what I was talking about, and they would say, actually, that happens to me, and could you tell me about this, and what are your experiences of this? And before I knew it, I had an international following, and just recently I've been given the title of one of the world's leading plus-size fitness experts, and I never saw that coming. So, you know, it's happened over a 10-year period, and I would say it's separate now to my own kind of journey and my own weight loss fitness goals, and it's much more about a campaign to challenge people's perceptions of overweight women and to just encourage women to give it a go. And I think particularly in terms of health, I went to my doctor in 2013 with some lower back pain, which was caused by picking my daughter up. And when I mentioned that I was due to run a marathon, he said I couldn't run a marathon, I was too fat. And that really spurred me on to take what was a bit of a hobby, this kind of blog, to being a real campaign, because I was just so angry that doctor, he wasn't my doctor, he was a locum, and he didn't want to hear that just the week before I'd done 18 miles around Hyde Park and that I'd been running for a long, long period of time, and this wasn't just some thing I had in my head. And I was determined to run that marathon to prove him wrong, but also then to use that catchphrase, you know, too fat to run, as a way of kind of starting those debates, you know, with parliamentarians and you know, and the people that can make changes, because ultimately the people that were reading my blog were the people that needed help. And I've struggled over the last few years to get my voice heard and to have discussions about health and what I've learned and what I've experienced. You know, and my background is in working in you know, local government, and I worked as a project manager on the Olympics, and I've done lots of work in culture and sport. So from a you know, I can work quite strategically as well as, you know, being a runner and giving practical advice.
Could I go back to that, the attitude that you ran into with, you know, not your own GP, but the locum GP, because we've just been hearing, and you were with us, I think, when Dr. Bird was talking about the difficulties of getting GPs to understand these issues.
Yeah.
Do you find with the blog and the contact you have with other people that are going down this particular route, that are trying to take exercise, that are doing runs maybe, or other forms of exercise, is that something that you've heard that other people encounter too? Do you think it is common? Because you've experienced it. It'd be interesting to know if other people experience it.
Yeah, I mean, I'm very connected to a lot of kind of social media groups for overweight women, so what would be described as kind of fat positive groups. And the experiences of women going to their doctors for advice about weight loss or health, you know, fitness, but also, you know, just going to the doctors for a sore finger, and before you know it, you're being told off about your weight. So I think there's a lot of mistrust with overweight people, and they think, actually, I'm not going to go to that doctor's about that niggling pain that I've got, because I know he's just going to have a go at me about my weight again. So, you know, that's what I hear a lot, is that there is a mistrust.
And do you think the NHS can cope with people who haven't been active becoming active? Because that's an important part of what we've just covered.
Yeah.
With the whole notion of people moving from inactivity to activity. But if there are medical issues, you seem to be saying that people will ignore those because they don't want to be lectured about their weight.
Yeah, I mean, I think you know, if I have a campaign to get 1 million fat women running, and if they all do it tomorrow, then the doctors' surgeries might be bombarded with people with twisted ankles and shin splints and all of those kind of things. So, you know, of course there possibly will be an impact, but it's about a gradual introduction to the sport of running, not, you know, going full whack and signing up to a marathon. And I've been developing a scale which I think could really help doctors, actually, and it's a scale that goes from non-runner to contemplator to, beginner. And because we often talk about beginners, but actually a beginner could be somebody that was very active and they, in a former life, or somebody that's just had children and is coming back to it. So I don't think the word beginner in running is very useful at all, which is why I've developed this scale which kind of talks about plodders and joggers and sloggers, because again we assume that overweight women are new to the sport, and actually the research that I've done via my website is the women that have been enjoying running for 10 years, and actually their weight is nothing to do with the reason why they run. They run for health and happiness, not to lose weight. And it's one of the reasons that I stopped talking about my own weight loss on my website, because I was just sick of telling people whether I'd lost a pound or not, and it being linked to kind of a sense of failure, or I couldn't give advice if I was myself putting on weight. So now it's not about weight loss, it's about health and happiness.
And just a final point about motivation. I mean, clearly that seems to be coming out as an important issue. You seem to have made a lot of progress just on your own motivation, but how much do you think that's important with the people that you're talking to through your blog, through social media?
I think
having friends, having a network.
It's so important to have a network, and I think it's easier for them not to be friends. I think it's easier to be people that you don't know. I mean, I run something called the Clubhouse, which is a membership scheme. It's like a running club for fat people, basically, and we have members all over the world, and they give each other that real kind of practical support of, you're feeling rubbish, maybe a walk today will just make you feel a bit better. And if you can't get that support from your immediate friends and families, which quite often you can't, because again you feel like you're going to get told off or they're on a different level, the technology enables you to form really close friendships. Facebook for me has been a fantastic way of communicating with overweight women. I've probably got 6,500 women on our Facebook page that interact every day, and I do something called One Big Fat Run, which is a virtual race which happens monthly, and there are women that have done that for 18 months now, and you've seen their weight come down. Women that have kind of reported back that they've just left a job that they hated because they've now got the confidence to go on. So, it's not just all about weight loss. It's just about kind of feeling part of a movement, a community of of women who feel similar to you.
Do you have any male members?
We do secret ones on the Facebook page, yeah. So, I mean, the Clubhouse is the only thing that is exclusively for women, because a lot of the feedback that I get is that running clubs tend to be run by men, and that is part of the problem. So the Clubhouse, which is the only real paid-for thing, is women only. One Big Fat Run is inclusive, it's for anybody, and you don't have to be fat to do it. It's more of a mindset thing. It's about scale rather than dress size, and we have a lot of men, overweight men, that do take part in that.
What do you think? You said to go to, you worry about going to a GP because they'll just have a go at you about your weight, which is not, I know how difficult it is to lose weight. It's not something that's going to make you lose weight. It's going to make you go, stuff that, I'm going to have cake.
Yes.
What do you think GPs can learn from how you've got people to overcome their worry about their size?
Yeah, I mean, I was so excited that Dr. William Bird was here. I think I have a major crush on him, because what I say, he says much more.
Yeah, I think we've all
I mean, he says things much more eloquently than what I can, but he was the first doctor that said that you could be fit and fat. And when I heard that out of the mouth of a doctor, I almost exploded. And I think just that phrase alone, for doctors to accept that that is a possibility, would be helpful, because we make these assumptions based on things like BMI, and BMI is not an indicator of health, in my opinion, in my experience. So I think, I guess I don't know the ins and outs of the GPs and the way all that works in terms of their training, but I often think, what would I say to 400 GPs, and I think, do they have access to the imagery of things like This Girl Can, which is a fantastic campaign, but what would they make of my campaign? And, I would love to have those conversations with those doctors. Because they do have a difficult time. I think about that doctor who had 15 minutes with me presenting with back pain, and perhaps I would make that assumption, big girl, Yeah, so I think it's tough. I think it's tough because as human beings we do make assumptions. But I think, changing the terminology, I mean, it's why I use the word fat. And before, a couple of years ago, I would shudder myself at saying that. But actually, what I've found through discussions is that the term overweight isn't that useful, because you're making a judgment about that person and saying that there is a sense of normal. And actually, for me, what I have here is normal. This is me. And I'm not that bothered about getting into a size 12 pair of jeans. I just want to be healthy and happy for as long as I can. So I think terminology is useful as well. So that's why I continue to use the word fat without shuddering anymore.
Thank you. I apologise for being late. I had a whole lot of phone calls to deal with this morning. But I was fascinated by the person who had a bit of a crush on this presentation. And particularly the disaggregation, to use the formal term, of heart disease from weight. And he was saying that not only do you not need to go to the gym, really, you just need to walk and get your heart rate up, which I thought was fascinating. There were sort of cost aspects there. But I just wondered whether you do, as part of your work, talk about weight reduction where necessary and the possibility of diet. And you have one or two closet men in the background in your great... And I try and practice what I preach. And I've actually given up bread for Lent, which I think has been a fascinating exercise, because I think white bread, there's a lot of issues about white bread anyway, and I've just stopped eating it. And I found I've lost, I don't know, dare I say it, a couple of pounds without actually doing anything.
Yeah.
Although members of Parliament tend to walk a lot, because this is a huge estate and we have offices and outlying buildings, and we get bells that say we have to vote within 7 minutes. So we're often running all over the place to get in. So I think we probably have an inbuilt advantage here with the division lobby, the division system. But so do you what do you think about diet and advice on weight generally? And
I think there's two things there. I think the idea of stress, we are bombarded in the media with what we should and shouldn't be eating, you know, both from a number of calories point of view, but also in terms of, diet. So should it be paleo? Should it be Slimming World? Should it be this? And as a woman who wants to lose weight, who do you listen to? So you get, majorly stressed about that. You might start something, it works for a little while, then real life comes in and you stop. Then you feel like the failure rather than it being the diet being the failure. So what I promote is much more about mindful eating. So listening to what your body needs from a nutritional point of view, but also what it wants. When I want chocolate cake, I want chocolate cake, and I will have chocolate cake. I'm not going to go and get a chocolate cake that's pretending to be chocolate cake and isn't actually real food. So, I sometimes go into the supermarket and I walk down all the aisles and think, that's not real, that's not real, that's not real, that's not real. Where is the actual real food? So I talk a lot about eating real food that grew on trees and things like that. But if you do want a McDonald's, for goodness sake, have a McDonald's, because I think the stress that is created by abstaining from these foods that are morally wrong just makes you live a life that's just dreadful. So I think that's the one thing. I think the other thing that I was interested in what you said is about walking, and I agree that walking is a very good form of physical exercise, but I think people need to walk like a runner, so they have to walk with the mindset of a runner. So it's not about speed, it's about intent. So my mum, who is quite unhealthy and quite overweight, says, I don't need to exercise, I walk everywhere, I walk every day. But she doesn't walk anywhere with intent, so she poodles along and it doesn't have much of an impact on her health. So I always say to the walkers that are on my site, have a plan, think about how you're fueling, look at to increase either in mileage or in speed, get your heart rate. And I think there is a tendency when doctors say, do something less vigorous than running, try walking. But it's boring to just walk up the same route every day. So I think you have to have that mindset of somebody that's training for something. So walking's fine, but have the mindset of a runner to do that.
Interesting, because in the army, the standard marching pace is 120 paces to the minute.
Yeah.
And the light infantry actually have a faster rate, and that part of that reason for that pace is to keep people in condition.
Yeah.
You've talked about the This Girl Can campaign, and we've touched on it a few times and looked at that, and clearly that's very important. But in terms of the input that you get from people from your blog, your whole network on social media, do you think that there are specific barriers that we need to focus in on that are stopping women becoming active? Out of all the things, because I think there was a range of things researched and found to be barriers, but are there which ones would you go for if there were sort of two or three?
I mean, I recently did a piece of research, and the 3 headlines that came up were fear of being ridiculed, so feeling self-conscious and that everyone's looking at you, finding kit that fits. In the UK, it's near on impossible to get technical running gear, anything larger than a size 18, and even to get a size 18 in some items like a running jacket is impossible. So that is a real barrier, because no woman wants to dress in men's clothing to go out for a run where there's the risk of already being laughed at. So that is a real problem. And initiatives like Park Run and Jantastic and all of these kind of running things that are there to get more people active, they themselves don't provide t-shirts in anything larger than a size 16. So it's really hypocritical that the government pump money into initiatives, but at the end line somebody goes to sign up and says, I'm not going to sign up for that because I can't get a t-shirt in my size, so why should I? So kit that fits is really important. And then the other one is about feeling too slow as a runner, feeling like you're too slow. And that's a real barrier. It's why I never joined a running club for all of those years, because I didn't want to be the one struggling at the back. So we need to create clubs or events that are specifically designed for people starting at zero, and that's what my One Big Fat Run virtual event is about. You can walk it, you can crawl it if you need to, and it's not about the time that it takes you to get round.
Well, if I just finish this point for me, I think that the point about embarrassment, lack of self-confidence, feeling self-conscious about being last is actually quite important, and there's possibly something about the design of events. The first time I ran a half marathon, there was a sweeper ambulance going alongside me all of the time, saying, "Are you okay? Do you want to stop? Do you need anything?" And you feel like, "Yes, I want you to go away, leave me alone," sort of thing. But I think it's worth saying that there are events whereby I don't think people who design things like this understand how much that's a strong feeling, really, that you don't want to be running along with the man dressed as a beer bottle. You know, if you're doing half a marathon, you don't want to be with all the jokers, you know, doing it in fancy dress. That some events actually mix it so that you can see the fastest runners at certain points, and then you feel like you're part of the thing that they're doing. Otherwise, it's you just jogging at the back. And you know. But
again, it's about being explicit with language. So One Big Fat Run, people know what this is about. This is about fat people running, so they're much more inclined to take part, because they know we're not going to be comparing speeds and there's going to be somebody probably slower than them. So I think being explicit, and I'm really trying to take my virtual run and get some backing to actually roll it out across the UK.
Could you explain how that works? Because I don't think we've come across a virtual run before.
So a virtual run is really simple. You say you're going to do it, you tell people on Facebook you're going to do it, and then you do it, and after you've done it, you tell everyone you've done it. So it's all done via social media, and you have to make your mind up to do it and go off and do it on your own, or you can do it with friends. So we have a lot of kind of groups of runners all over the country that have it in their diary, and they know the last Sunday of every month is One Big Fat Run, and they do it, and they feed back via social media. And the photos that I get of women doing it with buggies, with their dogs, you know, in the snow, in the rain, you know, it's fantastic. But I think if there were, alongside the virtual run, if there was the opportunity to, in your community, go to a certain park once a month and take part in something that's really inclusive, that doesn't have a specific start and end point, because that's another thing that people are really fearful of, that lining up at the start line and everybody goes off and you're left behind. So the way that we're looking to design this event is that you turn up, you know, in the morning, and there are a range of different start times, and it's much more laid back and kind of inclusive. Yeah.
Sorry, David.
David, you wanted to make a point?
Yes, I did. I was thinking of another issue which was come up in earlier sessions, and that is what I've called dress size deception, where the sizes of particular, I don't think it applies to men of women's clothes, have been adjusted to make people think they're slimmer than they are. And do you think that has any bearing on your work?
Yeah, I do.
What do you feel about it?
As a plus size runner, I don't really look at the labels. I look at the clothes and think, does it fit me? And often we'll because obviously it's lycra, you can stretch into items. So, you know, people will say, well, there's not a problem with kit sizes because lots of big people do run, but what they don't know is that they're stretching into clothes that are too small for them. And I think that, you know, some of the big brands, Nike and Adidas, you know, they've got a responsibility to provide clothing. I think it borders on, you know, discrimination that they stop at a certain point. I don't know if that answered your question properly.
There must presumably be a market.
There's a demand for it. I mean, I launched, not that I want to sell hoodies and T-shirts for a living, but I launched a range of hoodies and T-shirts with Too Fat to Run on them, and they sold out, and they were in large, extra large and extra, extra large. But actually, it's impossible to get anything larger than an extra, extra large, which is about a size 20 to 22, in small quantities. So, you know, I'm unfunded, I don't have any government funding, I'm doing it all from scratch, you know, as a startup.
So you see the definite need there, and
there's
you'd
a
like
need.
To see more of these supplied, the right clothing, because it's easier to run as a woman if you're wearing supportive clothing, anything else. Can I ask a question relating? I mean, clearly there's some amazing work you've done through social media, and you've made the case why that's a very supportive network. Do you feel that you would also like to be able to reach out to those women who don't use social media, so those who are not connected through the internet? Have you had any ideas about what you might be able to do to reach out to those who don't use the internet?
Yeah, and it is a big problem. Women say, you know, I saw you in a magazine, I don't normally use Facebook, or I don't use Twitter. I think my idea for rolling out One Big Fat Run is the kind of answer to that, so that people, and the idea is that it would be led by the women in that community. So it would be, you know, larger active women in their community volunteering to lead this event once a month. So they're more likely to be the advocates and the ambassadors and to go out and knock on doors and get people to that event every time. And I think that is where you wouldn't need to use social media, and there would be something every month. And I know that when I first started out, if I didn't have a race in the diary, there was no urgency for me to go out and train. So people tell me that knowing that this is coming up at the end of the month means that they do go out, you know, in the 3 weeks leading up and practice. So it seemed like once a month was a reasonable kind of milestone for people to work towards.
Because I mean, there are already in place schemes like Walk and Talk, for example, and Walking for Health. Do you think there's an opportunity to tap into those, which are not designed for, say, the Ramblers Association, which is a fantastic organisation, but for people who are just starting out would be a bit off-putting? Do you think that in the same way you could tag
and I think it's like, you know, if you don't see a lot of overweight people exercising because they do it in secret. I mean, I have women that tell me they run on a treadmill in their shed because they just don't want to be seen in public. But that's part of the problem. Because we don't see many overweight women exercising in public, other women don't think that exercise is for them. They think it's for all of the slim people that they always see out in the parks. So being visible, and the women tell me, actually, I get a lot of feedback that say, I bought your T-shirt because I want to support what you're doing, but I always thought I wouldn't be very confident to go out wearing a T-shirt that says Too Fat to Run. But I did, and I felt so empowered, and when people looked at me, I didn't care because I'm on my own fitness journey. So there is something about reversing that kind of psychology stuff and getting people to feel like it is their right to be in public and exercise, and they shouldn't have to make apologies for themselves.
Yes, thank you.
Do you think there's something very valuable about the explicit nature of your language? Too fat to run, one big run. It's not euphemistic, it's just saying it like it is. And do you think people feel sometimes talked down to by all the euphemisms, which basically, you know, we all know what the issue is. It's people, fat, but talked down to through the euphemisms and made to feel even worse because people call it fancy stuff.
Yeah, I think the word obesity, when somebody says obesity, I think fat people think, oh, they're not talking about me, they're talking about, those people we see on the news items, so I think people don't relate to that word. It's a medical term. When you say fat, we all know what we're talking about, and actually there's a lot of slimmer women that are still fat, so you can be a size 12 and still have quite a high body fat, so it's about self-definition. So I don't go around calling women fat. I don't say, oh, you're fat, come and join my club. That's not what it's about. It's about people self-identifying and thinking, actually, this is my tribe. These are the people that I want to train with, not the people in the running club that all look stick thin and are really, really active. And I think, lots of money's been put into physical activity programmes specifically designed for fat people, but fat people don't know they're specifically designed for them, because the imagery is wrong or the wording is wrong, and we just need to be explicit, but not in a you must do this. It's about looking at the barriers and designing programmes that people want, things that people want.
Can I just come with I think that somewhere here, I'm not sure I can articulate this quite as I want it to be in its final form, but there seems to be a very important differentiation here to make about somebody who can be large but internally in condition. Mm. And somehow there must be a message to get out that by walking, going back to Dr. Bird's point, you actually reduce the chance of heart issues.
Yeah.
And if we can somehow convey to larger people that if they exercise in a certain way, they are well within, and they can't be put into this overweight, obese category. Somehow we need to break this out. I'm not quite sure how we do it, but I think somehow if you can create a feeling of self-esteem through what you're doing, that makes people who are larger be able to say, I'm large, but buddy, my ticker's in great shape, and my digestion's regular, which of course is another thing that comes with proper exercise. Anyway, I leave that thought with you.
I mean, because ultimately I don't really care whether the women who follow my blog lose weight or gain weight. That's not what I care about. I care about their self-esteem, their health and their happiness. So, and I think we need to look at the wider picture and not necessarily just be ticking. And I think a lot of these kind of programs that are designed for overweight people measure them, and success is about whether they've lost weight or not, and I just don't think that's...
It's been a very powerful message today, and very well made, and as you said, this is about your health and your happiness, and you've been a fantastic advocate for it, I know. So
and Jen, just come in and say thank you, because women, when we try to lose weight, we all know that if you go to the gym, actually you put on weight because you put on muscle.
That's right,
and you get bigger, but that's muscle. And no one ever says it, so thank you.
Thank you. It's been fantastic to meet you. Really, really great that you came today. Thank you very much, Jude.
Thanks for having me.
Great.